Welcome, everyone. We're thrilled that you've joined us for our webinar today. My name is Christina Canton, and I'm a perinatal consultant with the Champlain Maternal Newborn Regional Program, or CMNRP, as we refer to the program. And I'm also a fourth-year PhD in nursing student at Queen's University. So CMNRP is a regional program whose goal is to improve perinatal and newborn care in Ontario Health East. And CMNRP's goal is to ensure high quality integrated services and care at the right time, at the right place, and by the right provider along the continuum from pregnancy through the postpartum period. So I'd like to begin by acknowledging the land that CMNRP operates. We recognize that CMNRP's members and stakeholders are located on the traditional Indigenous territories across Ontario. The CMNRP office is located in Ottawa, which is built on the unceded Algonquin Anishinaabe territory. And the peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. So I invite you to reflect on the land you are on, who are the traditional keepers of the land, and what is the treaty relationship, or if it's unceded territory. We recognize that Indigenous practices of health and well-being have been in place in this territory since time began and are maintained to this day. We acknowledge that there's much work to be done to honor Indigenous women and families' pregnancy journeys and to bring reconciliation to healthcare in Ontario. We acknowledge our role in collaborating with Indigenous peoples to raise awareness of Indigenous peoples' challenges in the perinatal period, and we pledge to continue to ensure clinical practice care is respectful and safe. So this is also a time to reflect on and acknowledge the harms and the mistakes of the past, and to consider how we each, in our own way, can move forward in the spirit of reconciliation and collaboration. We are truly grateful for the opportunity to live, learn, work, and play on this land. And we remain committed to and acknowledge responsibility for building and improving relationships with First Nations, Inuit, and Métis people. On the screen is a resource from the National Collaborating Centre for Indigenous Health, and it's one of many resources that can be used by health and social service providers to improve their practice so that we're able to provide culturally safe, humble, and trauma-informed perinatal care. So I'm absolutely delighted to introduce our speakers for today. We have some phenomenal people. Beth Tupela is a registered nurse with 15 years of experience in healthcare profession. She has worked in 3 different provinces, and prior to her work with Ask Masi, she was involved in opening and operating the first hospice residence in Nova Scotia. Beth is currently completing her MBA at Carleton University, and she is working towards her formal project management professional certification this spring. With her is Dr. Jasmine Gandhi, who is the Medical Director of Perinatal Mental Health at the Ottawa Hospital and an Assistant Professor of Psychiatry at the University of Ottawa. Her academic focus is on improving equity in perinatal mental health care delivery, as well as medical education in women's mental health. She's a consultant liaison psychiatry and interpersonal psychotherapy as well. Currently, she's working with the Ottawa Birth and Wellness Centre as well as CMNRP to implement a perinatal psychiatry access program for Ontario East known as Ask Masi.
Thank you so much for that very warm welcome, Christina. And I'd like to, Christina very humbly introduced herself at the beginning of this seminar, but I'd just like to highlight that Christina herself is a nurse with 23 years of diverse clinical education, research, and leadership experience. She's been working as a perinatal consultant with the CMNRP since 2012. Perinatal mental health, addictions, and substance use health are the major foci of her work. In 2022, she led the formation of the inaugural Perinatal Mental Health Community of Practice, which we all benefit greatly from. Christina collaborates with researchers, educators, clinicians, and leaders to integrate best practice standards and facilitate health system change at the local, regional, provincial, and national level. She is a PhD in nursing student at Queen's University, Kingston. In 2022, she was awarded the Doctoral Research Award Canada Graduate Scholarship from the Canadian Institute of Health Research. She is a wife and a mother raising 2 young men. So thank you so much, Christina, and CMNRP for having Beth and myself here today. Now that the audience has gotten to know who we are a little bit, perhaps we can launch our first poll question for you, which asks, who is here today? Who is joining us in this? So if you could just take a minute to answer the poll questions and share your profession with us.
So we have a great group here today, and I think it's started to slow down. So Charlotte will share the results here so you can see. Jasmine?
Amazing. Look at that. I love it. Look at all the nurses that are here today. Welcome, everybody. And we've got a nurse practitioner and a few physicians, and a couple of midwives and social workers and people from child welfare. Welcome. And to our allied health professionals, it's great to know who's in the audience today. So please, we're hoping that this talk speaks to a wide variety of healthcare providers, and it's fantastic to know that that's who we're reaching in our in our um, in our talk today. So just a disclosure of financial support. This program has received financial support from Daymark Foundation in the form of an unrestricted educational grant. And for those of you who are physicians, this seminar is worth one CME credit from either the Royal College or from MainPro. Okay, so in terms of talking about today's learning objectives, at the end of today's session, we are hoping that you will be able to describe time-efficient ways to screen for depression and anxiety and incorporate high-yield assessment questions into your practice. Before I even do that, maybe I'll launch the second poll. I'll ask Charlotte to launch the second poll. How do you currently identify concerns about your client's mental health? I'm just curious, and please enter all that apply of these various activities. All right. Wow. Well, these are fantastic results. Look at that. 97% of you will actually directly ask your patient, your clients, and observe your clients. A third of you will actually even ask families and friends of your client. And about half of you are using a school screening tool. That's very encouraging to see that a quarter of people here are actually using a screening tool with all patients or clients, whether or not you have any concerns. That's a really, to be honest, I feel like I might be preaching to the choir here, guys, because you guys are the most enlightened crowd that I think we've had the pleasure of speaking to, given that there's a quarter of you already doing this, and nobody is not actually asking about concerns about mental health. That's very reassuring. So in addition to finding time-efficient ways to screen, for those of you who may not be doing it regularly, we'd like to also explain a step care approach to perinatal mental health, and for you to walk away from this seminar without at least 2 local resources that you can give to your clients and patients. And we'd like to introduce Ask Masi as a service that you can contact for support and collaboration in order to facilitate early intervention for your client's mental well-being. So mental illness is the most common complication of childbearing. If you think of every perinatal individual that passes through an obstetric care provider's office, everybody will get their urine dipped, their blood pressure taken for gestational diabetes and gestational hypertension. But routine inquiry into perinatal mood and anxiety disorders does not happen, despite the fact that 1 in 5 individuals will actually suffer from a mood or anxiety disorder. And this is throughout the 20 to 25 healthcare contacts that this individual will have over the course of their pregnancy and the postpartum year. So we're left with 75 people going undiagnosed, and only 8% of those identified actually getting connected to treatment, which is very concerning, because not only are there consequences to the woman or the perinatal individual, there are consequences to the baby in terms of the most preventable adverse childhood experience, having a parent with mental illness right at the get-go, and impacts on the toddler and the co-parenting partner. We also know that it's very costly to our system, $150,000 Canadian per mother-baby dyad. Suicide is also the 4th leading cause of maternal mortality, which I think people are now starting to realize, and is quite a disturbing statistics. It's probably number 1 if you add in deaths due to addictions or substance misuse or overuse. The key problem is that providers don't necessarily want to ask, because they are worried that they either the questioning is not invited, or that there is nothing to do after they've gotten a positive answer to their question. The fact of the matter is that women will not offer, but in surveys, 97% of them will say that they want and they expect to be asked about their mental health. So if we look at mental health, that means different things to different people. As a psychiatrist, the most common disorders that present in pregnant or postpartum individuals are major depression and generalized anxiety disorder. There's definitely more than these two, but by and far, these are the largest and the most frequent. To actually diagnose these conditions, I've listed out the DSM criteria here. The DSM is our Bible that kind of dictates how we need, what criteria, what symptoms we need to elicit to get to make that diagnosis. For major depression, it's 2 weeks of either low mood, and something I'd highlight to you is irritability is also a symptom, not just low mood. And often especially the postpartum individual who might have a toddler at home as well, it's not so much this sort of depressed and low mood, it's actually the irritability that we see more often, as well as 4 of the following symptoms. And if you look at that first letter, SIGI caps is our common mnemonic device for 4 of those for 2 weeks at least. Similarly, for generalized anxiety disorder, it's 6 months of worry about lots of different things that are difficult to control, as well as 3 of these symptoms. IC rest is the mnemonic device for this. This is really complicated, and we're not trying to turn you into a psychiatrist with this seminar. We're just giving you tools of, okay, this is the kind of thing that you might be looking for. Luckily, there are really terrific scales, validated scales that you can use for each of these, that are tools that you can give to the patient or your client in the waiting room or while you're doing other things like documenting. And they can fill it out rather quickly, and you can score just as a screening tool to, bypass you having to do this all by interview. Time is valuable, and everybody attending this seminar is extremely busy in their clinical practice. So I'm going to go into more detail about these scales, but also just to highlight that the Columbia Suicide Severity Rating Scale can help you to flesh out a little bit more about suicide risks. So let's talk about this a little bit more. We don't just ask about symptoms. When I'm doing an assessment, there's lots that I want to understand. I want to understand the context in which symptoms are happening. I want to understand what are potential supports that this person brings to the table, and what are potential stressors that are going to make this a more difficult journey for that person. And so if we look at some of the risk factors, having a personal history of mental illness, as well as a biological family member history, particularly in first degree women relatives, is a really important biological risk. As are stopping medications, which have been effective in the past in order to prevent and protect the pregnancy. And having symptoms of mental illness in pregnancy is a real risk factor for developing more severe symptoms and persistent symptoms in the postpartum. Things like gestational diabetes, preeclampsia, having a traumatic delivery, having an infant who is sick, requires NICU admission, having a multiple kids like twins or triplets, and having difficulties with breastfeeding is a huge risk factor. Perfectionism is strong in women who are struggling with their mental health. At this point in life, by the time most people are having babies, they've always had a 5-year plan. They've worked to that 5-year plan, and they were successful in life because they had a goal and they were intentional about seeing that goal through. Having a baby, as those of you who work in this industry know, is all about giving up control. So when that's something that you're not used to doing, which is most of us, it can really be something that trips people up, as well as isolation, conflict in the couple, interpersonal, intimate partner violence, and a trauma history. These are all really important things to understand. At the base, you have basic housing, financial security, food security. If you can't build and feather your nest, it's going to be very difficult to maintain your mental health during the peripartum. And of course, please don't forget about cultural and intergenerational trauma. So if somebody's a refugee or they're of Indigenous and Black background, any people of color or minority populations, gender diversity, these are really important factors that are going to impact a person's mental health. Again, there is a great questionnaire that I will introduce to you because I'm not trying to turn you into a psychiatrist. I'm just highlighting some of the things that you may want to be aware of, but recognizing that when I do this, I take a good hour and sometimes 2 hours to interview a person, and that's not time that you necessarily have. When somebody is showing signs of clinical depression, it's very important to rule out bipolar disorder because it could be a unipolar depression, or it could be a depression that's part of a disease where you not only get depressive episodes, but you also get manic or hypomanic sort of super mood episodes. And that's really important to do because the treatment is very different. So it's important to understand if there's been a family history of bipolar disorder or a personal history of postpartum psychosis can often be linked to high risk of future bipolar disorder diagnosis. One question that I really like to ask is, have you ever had a time when you needed literally no sleep for at least 4 days, but you still had a lot of energy? You were acting like you were on drugs, but you weren't actually taking drugs. That's kind of a nice clinical question that I usually use. Having said that, there is another questionnaire called the Mood Disorder Questionnaire, which I'll go into details, that you can deliver in your waiting room to make life a little bit easier. And if there is anxiety, it's really important to rule out post-traumatic stress disorder, particularly if there's a trauma history of sexual, physical, and emotional trauma. Something that we don't often think about is financial abuse, and that is rampant. So something to think about. And again, a scale that I will go into in further detail. So I'm going to present you with a number of scales, and I'm going to give you a timeline that we at Ask Masi suggest that you potentially use. So if you look at the time of conception until 1 year postpartum, if you are seeing somebody preconception, there might be use of doing a few scales before then and looking at the medications that they're on and the implications that those medications have for the pregnancy. However, whenever you do an intake at whatever stage of pregnancy that is, we would suggest that you do the following scales: the EPDS, the GAD-7, and the antenatal risk questionnaire, just to do a quick baseline. And again, I'll go into these in detail, but if you have these printed off that your secretary can give to the person waiting in the waiting room to see you, or if you're there with a person, that should probably in total take no more than 7 minutes for a client to fill out. And that's a generous time allotment. And then, under 2 minutes to score for anybody in the clinic to score to give you a good sense. And then at 26 to 28 weeks, we would recommend doing an EPDS and a GAD-7 again, and then repeating the EPDS and GAD-7 along with the postpartum version of the antenatal risk questionnaire at 6 weeks postpartum, because a lot of things may have changed by that time. At any point after the baby's born, asking how the bond is with the baby is very useful. And again, if there is a positive EPDS, which looks at mood, to consider a mood disorder questionnaire to rule out bipolar disorder. As I'll talk about, the EPDS has one question in it that looks at suicide. If that question is positive, question number 10, you might consider the Columbia Suicide Severity Rating Scale. And if the GAD-7 is positive, you might consider a post-traumatic checklist, post-traumatic disorder checklist. So this is a very complicated diagram, but I'm going to walk you through all of these questionnaires and come back to this diagram. I just wanted to present it up front so you had a sense of what I'm offering to you. And again, these are suggestions, not necessarily mandatory things to do. So the EPDS is a really well-known screen. It's free, it's quick, it's available in at least 35 languages. As I say, it's a self-completed questionnaire. There's 10 questions. You score them from 0 to 3. Really great sensitivity and specificity in both the pregnancy and the postpartum. And again, as a reminder, we're recommending that you potentially do that at intake at 26 to 28 weeks in the pregnancy, and then again at 6 weeks postpartum. If there's only one screening tool that you think about doing, this would be the one that I would suggest, just because it does dip into so many different disorders, including anxiety disorders. And it is universally very easy to obtain, very easy to do, very easy to score. So a score of 10 to 12 would be considered mild and something that we would recommend psychosocial support, connecting your client to psychosocial support and doing another screen in 2 to 4 weeks to see how things are going. If you're in the 13 to 18 score, that would be something that we would consider as a moderate risk level and potentially suggest a psychological intervention. And later in this talk, we're going to go through some of these interventions and what they mean. If the score is greater than 19 or question 10, which is the one that asks about suicide, is positive, then we consider that a severe. So that's where you might consider doing the Columbia suicide screen or your own asking questions and getting additional specialized services involved. If there's any symptoms of mania, psychosis, risk of harm to self or others, that is urgent and should be seen in the emergency room. We don't generally recommend doing the EPDS immediately postpartum because there's just so many changes. However, if you feel that this is a high risk individual, consider rescreening at 2 weeks postpartum as well. Those first 2 weeks, you get a lot of the postpartum blues. And so you'll get a lot of false positives in those first 2 weeks. The GAD-7 screens for generalized anxiety disorder. Again, we're suggesting that this is something that you could do at the same time as the EPDS at intake, 26 to 28 weeks gestation, and again at 6 weeks postpartum. It's also free. It's only 7 questions that are scored 0 to 3. It's a patient questionnaire. It's available in many different languages with excellent sensitivity and specificity in pregnancy and postpartum. A score of 5 to 9 is considered a mild score. Again, something that we would suggest that you connect to psychosocial support and rescreen in 2 to 4 weeks. A score of 10 to 14 indicates moderate risk, so potentially room for psychological intervention. And over 15, you would consider it potentially a severe risk and involving additional specialized services. All of this speaks to this step-cared approach to screening and assessment. And we're going to talk about that a little bit later. Christina is going to bring us back to that. And Beth is actually going to walk us through specific examples of psychosocial supports and psychological interventions that you could consider. Similarly to the EPDS, if this is somebody at high risk, you might want to rescreen at 2 weeks postpartum. So the antenatal psychosocial risk questionnaire, and there's a specific one which has with family violence, drug and alcohol use questions, is something that we recommend that you do at intake during the pregnancy, and again, between 6 to 12 weeks postpartum. This is a free questionnaire validated tool available in 25 different languages. There's a specific pregnancy questionnaire, and there's a postpartum version as well. And there's also a father's version. If the score on this is 23 or higher, it indicates that there are enough risk factors in a person's life to indicate higher psychosocial risk. Also, if the questionnaire indicates significant mental health history or a history of abuse, that is high risk as well. If you score positively on that screen, it's important for you to know as the caring provider, but you'd want to check in to see if that person is interested in help, and if so, then connect them to the appropriate resources. As I mentioned, bipolar disorder actually happens to 1 in 10 of those suffering from depression, diagnosed with depression. If you look longitudinally, 1 in 10 of those people are actually suffering from a bipolar disorder, not a unipolar depression, where their mood is not only low, but also goes into the hypomania, mania perspective. So the MDQ is an excellent questionnaire to rule out bipolar disorder if you do get a positive EPDS. It's free, again, self-report. 15 questions, so a little bit longer, but they're mostly just yes/no questions. Not bad sensitivity, but excellent specificity. It's a positive screen if questions 1 to 13 add up to a score greater than 7, as well as question 14 is a yes, because that refers to the timing of symptoms if they all occurred together. And question 15, which looks at the severity of symptoms, is either moderate or severe. If you do screen somebody who positive for potential bipolar disorder during this period, it does warrant an urgent referral to psychiatry, because the risk of postpartum psychosis or a manic episode at some point, or a severe depressive episode with suicidal ideation at some point during the pregnancy or postpartum year is very, very high. The key also is to not prescribe an antidepressant alone. An antidepressant alone, of course, will push that person into a manic episode. You definitely want to have it in combination with a mood stabilizer as the first line of defense. Okay. And then again, if the GAD-7 is positive, you might consider a post-traumatic stress disorder checklist, PCL-5. Again, a free questionnaire, self-report, long one, 25 items, scored 0 to 4, with good sensitivity. Not as good specificity, but great at detecting symptoms. The cutoff score for probable PTSD is 31 to 33. And if there is a symptom that is rated greater than 2, it counts as an endorsed symptoms towards making a provisional DSM-5 diagnosis. So this one can be used not just as a screener, but as a diagnostic tool. But again, it's a self-completed tool that can be done in the waiting room or while you're doing other things. The one questionnaire that we recommend that is not a patient questionnaire, but actually a clinician delivered questionnaire, is the Columbia Suicide Severity Rating Scale. This is something that you would do if question number 10, which asks about suicidal thinking on the EPDS, is positive. So it actually gives you really great, plain, language questions that are direct, yes or no. They can be asked in any setting. So this tool has been widely validated, not just in healthcare, but in school settings, in community settings. It's a very good questionnaire. And I've cut and paste a version of it here. But basically, if question 2 or 3, if the answer is yes, it does need further evaluation. If question 4, 5, or 6, the answer is yes, this means that this person is quite high risk. You may want to consider getting immediate help, and also please stay with them or have somebody stay with them until they can be assessed. So again, I'm just going to re-show all of these tools and give you sort of a high level reminder of when you might do them. So at intake, EPDS and GAD-7 with the antenatal risk questionnaire. Repeat the EPDS and GAD-7 at 26 to 28 weeks gestation, and then at 6 weeks postpartum, do the postpartum version of the antenatal risk questionnaire with the EPDS and the GAD-7. And then, there's some follow-up steps if you do get positive results. All of these tools, I should say, are available on our website, askmasi.com, askmasi.com, and you'll get that information later. So the EPDS and GAD-7 are available in a fillable PDF that would score for you online, and you can just download it yourself. And we have links to the rest of the scales for your use in case there's something that you wanted to implement directly. And I'll hand it over to Christina at this point.
Perfect. Thank you so much. So I just wanted to share a little bit of information about stepped care. So pretty high level, but the stepped care 2.0 framework is an evidence-based system of delivering and monitoring mental health care. So this framework was initially developed in the United Kingdom, and it was implemented in Newfoundland, Labrador by Dr. Peter Cornish. And there's, on the previous slide, there's 9 types of services that are listed on the framework. We're just going back one slide. Yeah. And you can see that they're listed from low to high intensity, and not one type of service would be better than another, but the best service or support is one that's aligned with an individual's mental health severity. So that's that whole piece that Jasmine was talking about in terms of like assessing where the client or patient is in terms of severity. It also depends on their level of autonomy and their level of readiness. We know readiness is so important. And on this diagram, you can see the arrows that indicate the direction for those different aspects. So mental health, addictions, and substance use health programming that's integrated into a flexible system that best meets the needs of individuals, because the families, the individuals are going to be able to access the right service at the right time by the right provider. So person-centered mental health care is more affordable, as Jasmine mentioned, for perinatal mental health. It's very expensive if we actually don't provide early intervention and treatment. And we're going to have the best outcomes for families if we're not using the most expensive provider like all the time. It contributes to longer wait times, and it may not be an intervention that is in fact useful to the individual. So these are some of the key concepts that we're using in a stepped care model. So on the next slide, what I want to show with you is in July 2022, Daymark Foundation, which is a private family foundation, they brought together 18 stakeholders, including thought leaders and people with lived experience. And we discussed, how to actually optimize and operationalize the stepped care model and framework within a perinatal mental health context. And what you'll see is that here's this draft framework that came out of that meeting. But we added information like knowledge, social networks, and care. And we put the perinatal individual and family at the center of the framework. The framework was organized in a circle to kind of get away from this perception that there would be a hierarchy of service. Just because it's higher up on the ladder or the steps of service, it doesn't mean that it's necessarily better. The wheel or the circular format means that, again, people don't need the more formal or more scarce resources. And the other component is that people may need different resources at different times. So it does include the same kind of a framework in terms of low, medium, and high intensity options. And you can see that by the different colors that are used in the framework. So again, it's the same goal of matching to the level of intensity, to the level of need, and really considering readiness and trust. These are important factors when you think about the actual support that a person will attend. You know, if there's a referral or a suggestion, you know, if they're trusting their provider, then they're more likely to access that service and that support based on the recommendation. So on the next slide, I wanted to share with you some further work that we have done in the region with the perinatal mental health community of practice. And so we've continued to reflect on this and try to make it very relevant in terms of, you know, health system consideration around here. So we're situating the pregnant and parenting individual at the middle of this framework. And there's a variety of services and supports that are relevant to meet the needs of the individual. And so similar to the Daymark Foundation framework, we've used a fan of service categories, which indicate that, you know, you can select these based on the need of the individual. So there's no sequential step up or step down. It's just whatever is going to be relevant to that individual. And so other feedback that we received from our community of practice members is the importance of the social determinants of health. So, you know, as we've been working with the model, is on the bottom, we have positioned stable housing, access to food, safety, and basic income, as Jasmine mentioned, as being these foundational blocks that are so important to perinatal mental well-being, as well as many of the other social determinants of health. We're working on common language, so we've developed some definitions for each of these service categories, just so you know people are understanding. But what we realize within the community of practice as we have conversations, we're constantly learning about things that are available, and so there's services and supports across all these different categories. So that's just a very high level introduction about stepped care and about some of the work that's been happening nationally as well as regionally related to perinatal mental health.
Thanks, Christina. I'm going to invite Beth now to speak about some of the examples of services in each of these buckets that you spoke about.
Thank you for that. I only have a few examples here to share with you today, but it's also part of what we do with Ask Masi is keep a bit of a resource database on our end as well. So I'll talk about that briefly. But I did want to just give some examples of what Christina had talked about with stepped care, because we may not even necessarily know what that means. And we're still working out exactly what some of those definitions are. But just as an example, informational self-help would be information, credible information that's out there that a person would seek information and review on their own. So this is an example of just informational self-help, a booklet like this. There is a link there. Many of these you would find on our website or could also contact us. And I have a number of booklets, links, and things like that that could be provided to your patients or clients. So this is just one example of informational self-help and something that's out there. On the next slide, there are just a couple of examples of support groups, a couple that are local, and then also the international support groups run by Postpartum Support International. Those are virtual, and they actually have groups for a variety of different needs that people may have. So you'll see the links here or the names, and these are, again, examples of the information that we are collecting as part of our database. So if anybody ever does reach out to Ask Masi, and we chat a little bit around your client and your patient, then I can sometimes go back and see what else I know about based on cost, location, and sort of their mandate as well. So again, these are just a couple of examples, and I'm not going to go into much more detail on them. And then on the next slide, again, just gives an example of something that's a bit more sort of formal in terms of its structure. I have to apologize to Jillian. Her last name is spelled incorrectly there, but it's correct in the email address. So this is run through the Carlington Community Health Center. It has intake throughout the year, and it's an example of a psychoeducational workshop that's available for people. If on the next slide, I think there are, again, just a couple of images around what guided self-help might look like. That was another type of petal on that step care model. And this would be kind of slightly different, potentially from just informational. It's got a little bit more where folks are, interacting with that material, and it's guiding them through. So there are some workbooks that you can see there. And there's also this CBT booklet based out of BC. It's a little bit older, but I really like it. So those are just, again, a couple of examples, and there would be others out there as well. So again, those are examples, and we continue to develop our database. And so what I also wanted to kind of end by walking through with you is a little bit more about what we're hoping for with Ask Masi and this perinatal psychiatry access program. So along the top, we have an example of somebody here named Maya, someone who notices some changes in her mood at around 14 weeks. And then a little bit around the top bar there of what may happen now if people aren't feeling unsure. So we're using the OB here as one example, but it could be any healthcare provider that just may not really feel very sure about how to respond when this is picked up. They may lack information about screening. They may just not know what to do next. So they're going to just take a wait and watch approach. But then Maya feels worse at 28 weeks and her EPDS score is 17. So this healthcare provider is going to make a referral to the perinatal mental health clinic. Unfortunately, the clinic has a 4-month wait list, and at 1 month postpartum, Maya developed psychosis. As a result, she's admitted to the hospital. There's a separation between her and her baby, and this then puts her and her child at a higher risk of complications. So sometimes, this is not what we want to happen, but this is what sort of can happen sometimes with these waits and the way things may currently unfold. What we're hopeful for with Ask Masi and just sort of these, opportunities to learn is that the provider, the healthcare provider and the OB on this slide knows about Ask Masi and maybe has a little bit of additional training on screening and assessing. And especially then with mild to moderate depression, might feel that they know a couple of those next steps to take. So in this case, that provider contacts Ask Masi and refers Maya to a community resource that's been recommended by Ask Masi. And by 18 weeks, Maya is connected with a therapist and has started in a support group. And by 30 weeks, she's feeling better with remission of her symptoms and adjusting well to her new baby. So, this is, again, kind of a theoretical example, but these are sort of the things we're hoping to see, that people are connected to the appropriate types of care earlier and to the right type of care for them. So that is the end of that part. And I think what we wanted to wrap up with is sharing a very quick 2-minute video about Ask Masi. And then I think we have some time for questions as well that are potentially coming in through the Q&A.
And so we'll leave the, thank you, Beth, for that. And we'll just leave our contact information here while we hand it back to Christina to lead us through the next.
Yes, thank you so much. I love that video. So we're just putting a focus on everybody here for the question and answer period. So there's a button on the bottom of the Zoom webinar here for Q&A. So if you have questions or comments, please type that in the box. There's, oh, one just came in. So I'm a family physician that also does OB. I was told at a conference a few years ago to not use the EPDS routinely at the 4 to 6 week postpartum visit and to only use it on symptomatic patients, as this was creating a bigger doubt a bigger doubt and whatnot in the patient, creating a problem that maybe was not there. So anyway, can you comment on that issue?
So I think it's a really great question. Thank you for asking it. I will say that Canada's approach to screening has gone through a bit of a roller coaster over the last few years. So there isn't yet consistent advice on what to do. So what we propose here is suggestive. It's suggested, it's not mandated. And I want to be very clear about that. But we're not just pulling it out of thin air. We are going by guidelines that have been developed through the UK, the NICE guidelines, in the US, as well as Beyond Blue with Australia. So this is where we are pulling our suggested advice. I will say that the SOGC is in the midst of developing guidelines, and those should be released shortly within the next few months. I'm not sure. Christina's on that committee. My sense is that Canada is not yet there at saying, give this questionnaire at this point in time. So the advantage of giving and I will add for anybody in the psychiatry world or the mental health world that CanMat is also releasing guidelines specific to perinatal mental health later this year. And just to make a plug that we are having both the authors of these guidelines coming to speak in an annual course that we'll be giving on October 18th in the morning at the Civic Campus. So this is an in-person conference if you'd like to come and see. And thank you, Christina, for putting the links into the chat there. I think the bottom line is that the EPDS, all of these questionnaires that I've introduced are just that. They are just screening tools, with the exception of the PCL5, which, if used properly, and there's a little bit of extra stuff that I didn't go into, can be used to create a provisional diagnosis of PTSD. The rest are not diagnostic; they are screening tools. So they are not to be used blindly. They are to be used for a specific intention. If you would like to give that in a sort of regular, universal way in your clinic, we've suggested guidelines on timings that make sense based on other guidelines, other evidence, for you to deliver these tools, but they are not mandatory. And if you wanted to ask, that could certainly be possible. EPDS is valid at 4 to 6 weeks postpartum. It's only the 2 weeks postpartum when you've got a higher risk of the baby blues that you would just kind of wonder about the value of the results of that particular tool. So it is giving you information. I think a lot of the hesitation from, there was a CMAJ article released a couple of years ago, actually discouraging validated questionnaires at all during any point, because they were trying to encourage actually just asking direct questions. The reality is, though, is that clinics are really busy. You guys already have tons on your plate, and to carve out room to ask some of these questions, I went through all of those criteria, and some of you know them very well. It's just not realistic. So, these are validated screening tools that you can use at your discretion. I hope that answers the question. It's a very good one though. Thank you.
Yeah, and so continuing on the question about screening on intake, sorry, I'm losing my voice here for a moment. There's a midwife who's asking a question. She has patients coming at intake stating a history of PPA. So I'm assuming
Postpartum
postpartum
anxiety.
anxiety. And then do you have any specific recommendations for these cases?
Yeah, so the GAD-7 is the anxiety screening questionnaire. The EPDS also contains a subscale that taps into anxiety. And so these are scales that you can still use for this population. So anxiety and depression are the most common complications, mental health complications during pregnancy and the postpartum year. And that's why if you only have time or headspace to kind of put one tool to use, I would use the EPDS because it does tap into anxiety on a couple of the questions. But if you have the time to implement all of them, then I would highly recommend the GAD-7 as well, as sort of a gold standard that's used in other countries.
Perfect. Thank you so much. Concise answer. So I don't see any more questions right now. So what I can do while people still have a few moments to think if there's anything else, you know how to contact Jasmine. She's not far away, and Beth. All the information is on the website right there. This is just the very first part of our conversation. The next webinar we're having is on June 17th. And the focus of that one is actually on anxiety. So that's perfect in terms of the question that was just asked. September 16th, we're going to be focusing on depression. And then December 9th is about ADHD. So I'll pop a link into the chat, that has all of these webinar links. The Ask Masi website is the place to go. It has all the screening tools. It has all the contact information, has all these upcoming events that we've been talking about today. And that the conference in the fall is a really important opportunity. We think it's probably for sure the first event where we're going to have both of those guideline authors presenting and discussing about the guideline recommendations. So this is the place to be, October 18th, save the date for that. So we can actually engage with these guideline authors and have these discussions about how we're going to implement that in our area. So just to keep talking, because I don't see any more questions. Oh, there is a question here about public health nurse. Yay. We have many public health nurses from a few different units on the call today. And this person would like to know if you have any suggestions regarding clients who are put on a wait list, a mental health service wait list. How can we work with those clients in the meantime? Great question.
Excellent question. I'm actually going to pass this along to Beth because I think she will have lots of stuff to suggest.
So that is part of what we will sometimes chat through if you contact us, Masi, which is just to really try to explore what is potentially the most helpful for your specific client. So that is where that step care approach comes in, and just sort of knowing about what's out there. So really just sort of depending on what's going on, that's where, we might be able to recommend some inroads into individual therapy, so psychotherapy or peer support, or some of those workshops that I mentioned earlier. That's where there's, you might offer a couple of those types of things for a person to try while they're waiting. And then again, it would be based on the client's sort of specific situation, their symptoms, the severity, and what's going on. Sometimes it also means connecting them back to their, if they have one, primary healthcare provider, or to a healthcare provider that can support them while they're waiting for the specialist care through psychiatry. And we'll talk about that sometimes when a person contacts us, just to see what else could be done to support the patient or the client in the meantime. But that's where we would want to try to connect them to some of these resources right away, and not waiting for a long time.
Thank you, Beth. Yeah, so important there's always something to do while we're waiting. Yeah. This is a question for you, Beth, as well. Does Ask Masi have resources for fathers and partners who need mental health services themselves?
I do have a few, yeah. And also then just I also have a number of resources on general mental health that would be relevant for people. So we do have some, and yes, I do have a couple of resources for fathers or partners that may be helpful. Not as many as I have potentially for the pregnant and postpartum individual, but yes.
And I would just add that that's a reflection of the fact that there's not that many things out there for fathers. But if it is out there, we typically, Beth has got the information to give to you. If it exists, then the team has done a really great job of sort of scraping together all the resources. And the question asked by the midwife about postpartum anxiety, I'm just thinking I might not have fully answered that, because I think that might have been a resources question as well, about whether, so the question was, I am a midwife and have patients coming to me at intake stating a history of PPA. Do you have any specific recommendations for these cases? And so, Beth, I might defer that. I might punt that back to you again, just to re-answer.
Yeah, that's I think again it's exploring with that person what has worked for them in the past, and then seeing what they're receptive to now. Again, it could be from along that continuum. It could be connecting them with the appropriate group. It could be the use of Anxiety Canada's app. There are a number of things like that. It could be that workbook, or it could be managing it through medication and a conversation around that. So it could look like a couple of different things or multiple things depending on the client. But I think the key always is that there's something, and it's to do something, to start something, to offer something, and then to continue to stay in touch and to continue to either use those screening tools to you start with your baseline and see how the client is doing over time, but to continue to follow up and assess, and then to see what else may augment that, or that they can try if the first suggestions aren't working.
So
Excellent.
interesting, isn't it? Sorry to cut you off there, Christina, but I just wanted to comment that almost all of the questions, so we had 5 questions today, and 4 of them were actually in Beth's territory to answer, which is our experience of Ask Masi, that most of the questions are about resources and screening and stuff that doesn't need a psychiatrist, right? And that loops back again, that there's just so many resources out in our community that you can do interventions without waiting for that referral to a psychiatrist, if you're lucky enough to have a psychiatrist to refer to. And that step care model that everybody just thinks mental health, psychiatry referral, but that's actually only a subset of people who actually would benefit from psychiatry. A lot of people would actually really benefit from other interventions that are effective, evidence-based, and much more readily available. So that's the whole point, is we want to get you connected earlier so that your clients start getting better sooner. So this poll is great. We'll have to look at the beginning.
Yep. So just for the recording, people are watching it. So the question is, after this webinar, do you plan to make adjustments to your current practice? And we have 50% of people saying, I will ask patients and clients about their mental health. 55, I will routinely use screening tools like the EPDS or the GAD-7. 35%, I will use a stepped care approach to care when planning interventions. 80% will contact Ask Masi with questions or for more information. That's excellent. You're not sure? That's the place to start. And there were 10% that said other. So we would love to hear those other ideas that you have. So just as we wrap up, there's one final question in terms of just your personal thoughts about the effectiveness of the webinar today in terms of meeting your needs. And we really appreciate this high-level feedback as we continue to offer these webinar series. Today we heard that perinatal mental health concerns are common, that most people are going to have low to moderate severity of mental health concerns, and they're really going to benefit from information and community-based support Jasmine reviewed a variety of screening tools. Maybe some were new to folks. And EPDS, if you had one, like that screens for depression, anxiety, and then there's that question about suicide, you know. So we're just talking about validated tools for this population. Ask Masi, we saw an amazing video. This is a new service. This is an evidence-based program that we've adapted from an effective program in the States. And so really it's providers who are caring for pregnant and lactating individuals who have questions about mental health. So the prescriber consultation service is for healthcare providers who are prescribers. So those are the family physicians, obstetricians, psychiatrists who are on the webinar today. And then anyone who can contact Ask Masi for the resource referral aspect of this program. And so don't hesitate at all to reach out to the Ask Masi team. Here's the information on the slide. And then you can also reach out to them if you think your team would benefit from a targeted like education session as well. So those are kind of like the 3 pillars of the Ask Masi initiative. So I just want to thank you so much, Jasmine, for your amazing presentation, Beth, for all the work that you're doing to launch the program, and you're constantly collecting more and more services and supports and resources. So thank you both for your presentations today and the myriad of ways that you're supporting providers in our region and beyond. So we look forward to seeing you in June, if not before then. Take care.
Thank you.
Thanks, everybody.